Over to you, Dr. Muthukumar.
Thank you, sir, for the kind introduction. Good evening, everyone. Once again, thanks to Dr. Vivekananda for this opportunity, and I would also like to thank all my teachers in PGI. What I'm going to do today for the next about 45 minutes to 1 hour is take you through this topic of transplant glomerulopathy, trying to first get a feel for it, what it is and what exactly can be done. Can anything really be done? And if so, what can be done and at what level the intervention needs to be done? So first, let me ask this question: what is transplant glomerulopathy? We can simply define this as a morphological lesion of kidney allograft characterized on light microscopy by the duplication of glomerular basin membrane. So it's a very simple definition. The moment you see double contouring of glomerular basin membrane in a kidney allograft, you use the word transplant glomerulopathy. So this is obviously a light microscopic finding to start with. So what does this double contour mean, and why it has to be called specifically as, in a way it's a non-specific term, right? Though I use the word specific, in a way it's a non-specific term simply describing the morphological entity called transplant glomerulopathy. Now let's talk about criteria for diagnosing transplant glomerulopathy. Initially in Banff 1997, the definition was that more than 10% of capillary loops in the most affected glomerulus should have evidence of double contouring. Subsequently, in the most recent Banff, in Banff 2015, this was changed to double contours in only a single capillary loop by light microscopy. Now that's enough to make a diagnosis of transplant glomerulopathy. Now, as you will see here, this itself by light microscopic finding gets the grade of CG1B. C is the chronic score and G is the glomerulopathy. So it's a CG1B. So what is CG1A, or is there an earlier finding prior to the light microscopy? CG1A is actually glomerular basin membrane double contours in at least 3 glomerular capillaries by electron microscopy with endothelial swelling and or subendothelial widening. So the common theme here is that there is some degree of an ongoing endothelial injury and endothelial remodeling. Only the remodeling phase we are able to appreciate by light microscopy, and that gets the definition of transplant glomerulopathy. So what is the relationship between light microscopy versus electron microscopy? Now, there are 2 studies I would like to quote here. One, an ultrastructural change occurring over time was described in 7 patients who eventually developed transplant glomerulopathy by light microscopy, as compared with 8 controls who did not. So this is a serial biopsies showing in 7 patients compared with 8 controls. Here, endothelial cell swelling and vacuolization, as well as widening of the lamina rara interna, were detectable within 1 to 3 months and were significantly greater than in controls. The second study looked at 98 patients with forecast kidney biopsy done within 3 months of transplant. And as you can see here, the 3 endothelial changes, the 3 glomerular changes, endothelial swelling, subendothelial electron-lucent widening, and early glomerular base membrane duplication, was observed in about 65% of patients who were labeled as C4D positive AMR. So this 98 patients, if you classify them as C4D positive AMR, ACR with no AMR, are completely normal, no AMR or ACR, you can see that there was an association between a light microscopic defined AMR and an electron microscopic changes of endothelial swelling, subendothelial electron-lucent widening, and early GBM duplication. Okay, so we have a definition of TG. We know that TG is not only a light microscopic finding, even an initial or at an early phase, an electron microscopic finding will say or will give us a clue that what's going to happen in the future. So we have made a diagnosis of TG. Now the question becomes, so what? So is TG bad? Of course, TG is bad. This slide shows 3 major studies, or 3 studies which more than 50 patients that were involved. First is a Mayo Clinic study. This was published in AJT 2007. Here you will see a survival curve, which this dark black line showing 527 patients without TG and 55 patients with TG. Obviously, you can see that the moment a diagnosis of TG is made, the graft survival is poor. Subsequently, another study from University of Wisconsin that looked at 123 patients with a Banff 2013 defined chronic antibody-mediated rejection. Here, you can see that the median survival was 1.9 years after the diagnosis of this chronic antibody-mediated rejection. And finally, this survival curve shows our own study of 92 kidney transplant recipients who had a diagnosis of TG. Again, there are two lines here, one with treatment and another one is without treatment. Ignore that for a moment, I'll come back to it later. But as these two lines are closer, we can assume this to be a single line. Again, you can appreciate that the moment diagnosis of TG is made, then the survival, the graft outcome is poor. So we know that TG is bad. Now, when we say how frequent is this transplant glomerulopathy? Now, if you go through the older literature, there is some confusion with the terms. There has been a waste paper diagnosis of chronic rejection or chronic allograft nephropathy, interstitial fibrosis and tubular atrophy or IFTA, and transplant glomerulopathy. So all this in the literature has been used interchangeably. So it used to be like acute rejection and then chronic rejection, and chronic rejection included all possible diagnoses. Once the science evolved in terms of how to detect antibodies, and when people started accepting that over time, it is not primarily the cell-mediated rejection, but forming of antibodies, either a de novo or a pre-existing antibodies that causes injury to the graft. And once people started recognizing that, then what are the reasons why grafts fail? That concept started to change. It is now no more interstitial fibrosis tubular atrophy. Obviously, IFTA or interstitial fibrosis tubular atrophy is the final common pathway, meaning that any glomerular injury or tubulointerstitial injury can eventually result in an IFTA, which will be probably the best predictor of outcome. But the IFTA is not the primary diagnosis. Why and what results in IFTA is the primary diagnosis. And based on that, if you look at the current literature, we can see that about 10 to 20% of graft losses are primarily attributed to transplant glomerulopathy. Now, this is our own study of 130. We did a matched case control study of 130 kidney allograft failures. Now, you can see here, acute rejection contributes to about 21%. Several medical conditions put together about 21%. Glomerular disease that is not transplant glomerulopathy is like, say, for example, this is like a de novo membranous or a recurrent diabetic nephropathy, something similar like that, contributes about 19%, and transplant glomerulopathy about 13%. Again, if you see here, IFTA, not otherwise specified, where a clear reason for this fibrosis cannot be reached, that's only about 10% of patients. So transplant glomerulopathy is not a very common disease, but at the same time, it affects a sizable proportion of the graft, and it's an important cause of graft failure in the current era. Now, transplant glomerulopathy is a disease of the glomerular basin membrane. So it's a remodeling of the glomerular basin membrane. So let's learn a little more about glomerular basin membrane. Now, the major components of basin membrane are four: laminin, type 4 collagen, nidogen, and heparin sulfate proteoglycan. Now, heparin sulfate proteoglycan is a sort of an umbrella term, and within the glomeruli, agrin is the most common type of heparin sulfate proteoglycan. Now, if you learn about Alport syndrome and good pasture, you will appreciate this type 4 collagen, where it's sort of a triple helix, where alpha 1, 1, and 2 forms together a protomere, alpha 3, 4, and 5 forms another protomere, and alpha 5, 5, and 6 forms another protomere. So there are four primary components of glomerular basin membrane. As I said, laminin, nidogen, agrin, and collagen 4. Now, when we say an endothelial cell injury, how does the endothelial cell repairs itself? So kidney has plenty of blood vessels. You have the glomerular capillary network, the peritubular capillary network, and everything is lined by endothelial cells. So you have plenty of endothelial cells in the kidney. And when we say endothelial cell, how does this endothelial cell repairs? There are two main ways in which any endothelial cell can repair, or a new blood vessel is being formed. One is known as sprouting angiogenesis, and another one is known as intersusceptive angiogenesis. So in kidney, the current thinking is that this intersusceptive angiogenesis probably plays a major role. The moment when an endothelial cell is injured, sort of these two layers pinch together, invaginate, come closer, and a different lumen and another cell is formed. So this type of angiogenesis is probably the repair mechanism that happens within the kidney when there is an endothelial cell injury. Now, the integrity of the endothelial cell depends on what is known as VEGF, or vascular endothelial growth factor. Vascular endothelial growth factor, based on our current understanding, is produced by the podocytes, and it is acting on the endothelial cells on specific receptors known as VEGF receptors 2 and 3. Now, how this works, say for example, when VEGF-A, or vascular endothelial growth factor A, binds to VEGF receptors, it does two things. One, it causes the Rho-RAC signaling pathway, which results in actin rearrangement. Actin, as you know, is a cytoskeleton, the main protein component of the cytoskeleton. So this is rearranged, and then plasmalemal vacuoles, vesicles, or PV1 protein is recruited, which creates this fenestrations and maintains this fenestration. So we can think this of as like a coil spring, in which this coil spring maintains the fenestration integrity. And once the fenestration is formed, then this PV1 is removed. Now let me digress a little and tell you more about this VEGF. This VEGF is the primary culprit in preeclampsia. So when you have a soluble VEGF receptor, like an S-FLIT, which is like a truncated receptor that acts as a sponge and absorbs all the VEGF, which results in a relative deficiency of VEGF, and that results in an angiogenesis problem, and whatever we see, the glomerular endotheliosis that happens in preeclampsia. Now, the same concept has been utilized for cancer chemotherapy. A drug called bevacizumab, or Avastin, which is commonly used for several cancers, works on the same principle that happens in preeclampsia. So it sort of blocks the VEGF signaling, which results in reduced angiogenesis. That's why when we see patients in cancer ward who are treated with Avastin, they present like preeclampsia with proteinuria and hypertension, and nephrologists are called to consult upon these patients. Okay, so we learned that what is TG by definition? TG is bad, and how does glomerular endothelial cells function normally, and in terms of and during injury, what happens? Now, after all this, let's move to the next step. We repeatedly use the word double contour. What exactly is this double contour? Now, when we read about native kidney diseases, we are very familiar with this MPGN pattern of injury, which is basically the double contour that we see in the native kidneys. Now, there was an old nephrology forum in 1995, which beautifully describes the different causes of MPGN pattern. You can broadly divide them into three groups: immune complex mediated disease, chronic and recovering thrombotic microangiopathy, and paraprotein deposition disease. So in other words, the moment you see somebody presenting with proteinuria, do biopsy, and then the native kidney biopsy shows double contour. We run this quick checklist to make sure that any of these diseases are part of the reason why there is double contour. Now, the pathologist and the nephrologist from Mayo Clinic came up with a slightly modified version of this, especially with more knowledge available on alternate pathway complement disorders. They came up with a slightly modified version in which, instead of light microscopic definition or division into three groups, they went by immunofluorescence. So how does that work? So based on immunofluorescence, the moment you see an MPGN pattern or a double contour, the next step in the algorithm is see the immunofluorescence pattern and see whether there is immunoglobulin and complements there. And then tease out whether it's a monoclonal or a polyclonal. Or the second step or the second branch is whether it's purely a complement dominant or there is no complements and no immunoglobulin. So when you have an MPGN pattern with no complements in immunoglobulin, thrombotic microangiopathy is likely to be the cause. When it is immunoglobulin and complement components, you have to next check whether it's a monoclonal component or a polyclonal component, and the appropriate disease is there. And when it is C3 dominant, that's where you think of the alternate pathway complement problems, the C3 glomerulopathy, and your dense deposit disease. So in a way, this MPGN pattern of injury that was described in this forum in 1995, sort of it's the same thing but explained in a different way by using primarily the immunofluorescence findings. Now, the same MPGN pattern of injury in kidney allograft goes by the term transplant glomerulopathy. So, transplant glomerulopathy can be due to several causes. The most important is chronic active antibody mediated rejection. So, I'll call this ABMR. And then you have a small proportion, depending on different series, anywhere from 10 to 20%, where despite our best effort, you are not able to identify the particular antibody. So we do not know what that is. And when we say we do not know what that is, three things can be thought of here. One is a T cell mediated rejection itself is doing that, a thrombotic microangiopathy, and hepatitis C virus. So again, let me go over this. Transplant glomerulopathy is a broad umbrella term that simply means double contouring in a transplant kidney. The moment you see double contouring of glomerular basin membrane in a transplant kidney, the vast majority is going to be chronic active ABMR. If we are not able to appreciate or are not able to identify the antibodies, it is probably our fault that we are not looking at it properly, or the current test that's available is not sufficient to diagnose the antibody. Probably there is a small proportion of patients where they are truly antibody negative, in which case a cell-mediated rejection, a thrombotic microangiopathy, and a hepatitis C virus could be the culprits. Now again, this paper, this Kidney International 2011, is an often quoted paper that says all this can result in transplant glomerulopathy. But including our series, more and more newer series, we are not able to appreciate this TMA and hepatitis C virus as an important cause of transplant glomerulopathy the way we define, because hepatitis C is an immune complex disease. So when you have an MPGN pattern and when you have immune complex deposits there, then if hepatitis C is positive, you think of HCV. But classically, a chronic active antibody-mediated rejection that results in thrombotic microangiopathy does not have an immune complex deposit. Similarly, TMA, if the TMA is a single shot or a one-shot injury, then it is extremely unlikely that there will be a glomerular remodeling, which subsequently results in subsequently results in transplant glomerulopathy. Let me go back a little. So if you see here, chronic and recovered thrombotic microangiopathy is an important cause of TG. Yes, but the word here is chronic. So you need to have an ongoing endothelial injury. So here again, when you have an complement like an atypical HUS or an alternate pathway complement deficiency, where there is a slow ongoing endothelial injury, that's possible that it will eventually result in transplant glomerulopathy. But those situations are extremely rare. The usual sort of calcineurin inhibitor related or certain other drug related or a part of antibody mediated rejection, you get a thrombotic microangiopathy, and that's a one-shot injury. It's unlikely that they will develop into transplant glomerulopathy. So what this small subset denotes, probably a TCMR, where the acute cellular rejection is itself injuring the endothelium, or rarely thrombotic microangiopathy and possibly hepatitis C. Now, as I told you, in newer series, we are seldom finding these two as an important cause of transplant glomerulopathy, like the way we have described it. But this is again a study from PGI. where they looked at 266 biopsies, and 107 were transplant glomerulopathy, and 114 were thrombotic microangiopathy. So when they looked at biopsies with significant glomerular lesions, they found a big proportion of patients with thrombotic microangiopathy. So what is the spectrum of ABMR? Now, when we say antibody-mediated rejection, and I had used the word in the previous slide that chronic active antibody-mediated rejection, can we really separate antibody-mediated rejection into an acute and chronic? Probably not, especially based on the fact that the current definition of transplant glomerulopathy involves electron microscopy. Practically every AMR or acute antibody-mediated rejection, you will see some evidence of endothelial cell swelling, endothelial cell widening, some subendothelial deposits. So then, by definition, they become a CG1A, which means, again, by definition, it's transplant glomerulopathy. So where do you put the line and say that this is an acute antibody-mediated rejection and it's a chronic antibody-mediated rejection? Probably you can never put that line. If you, for a minute, try to conceptualize this as a continuous ongoing injury. Now, unlike a cell-mediated rejection, which is a single shot injury, antibodies are there. You are not going to completely eliminate the antibodies, and the antibodies are going to cause injury on a day-to-day basis or on a chronic basis. So if the antibodies that are present there are powerful enough to cause an acute insult, then there is a rise in creatinine. We make a diagnosis of acute antibody-mediated rejection. On the contrary, if there is antibodies that slowly over time start injuring the endothelium, then we don't appreciate an acute rise in creatinine. Instead, there is gradual remodeling of the endothelium. You get double contouring, and one day there will be proteinuria. We do a biopsy, and that shows double contouring. So if we try to conceptualize antibody-mediated injury to the kidney allograft as a continuous process, and depending on the severity and the strength of the antibody, you have an acute presentation, which becomes a classical acute AMR, or a chronic presentation, then it will be easy to appreciate the current Banff modification, where they have removed the word acute. So it is simply called active ABMR, and the chronic one is called as chronic active ABMR. So again, we need three criteria for diagnosis. One, histological evidence of acute tissue injury. Two, evidence of current or recurrent antibody interaction with vascular endothelium. And serological evidence of donor-specific antibodies. Now this I have provided in blue. Again, remember that this is a classification scheme or a criteria to make a diagnosis, more for not for an individual patients, because sometimes for an individual patients it will be extremely difficult to prove that there was an antibody at this time. At the time of doing biopsy, there may not be antibody, C4D may be negative, but this patient might have had a positive cross match before, or a presence of low level antibodies that we traditionally call as negative or non-existent DSA, right? So Banff has recognized all this. So that's why C4D is not a criteria for diagnosing antibody-mediated rejection. So if you see here, one of the criteria for saying an evidence of current or recurrent antibody interaction with vascular endothelium is the presence of peritubular capillary linear C4D or a microvascular inflammation defined by at least G plus PTC score, which is glomerulitis or a peritubular capillary inflammation. The combined score should be more than 2. So all this are the criteria for diagnosing active antibody-mediated rejection. Again, as I told you, this may not be applicable just like any other criteria or any other classification scheme. This may not be applicable for individual patients. When we want to report about acute or an active antibody-mediated rejection, it's better to show that this is fulfilling all the three criteria. But in several instances, when we want to treat patients at any given time, when we make a diagnosis of AMR, we may not be appreciating or we may not be finding all these three criteria. So what about chronic active ABMR? Now, morphological evidence of chronic tissue injury. Here, transplant glomerulopathy without any other cause, which is CG score or a chronic glomerulopathy score of more than 0, which means you're double contouring, or peritubular capillary basin membrane multi-layering, which is an electron microscopic finding where a CPTC score is more than 0, or arterial intimal fibrosis, plus an evidence of current or recurrent antibody interaction with vascular endothelium, and a serological evidence of donor-specific antibodies. So for these two criteria, it is similar to active antibody-mediated rejection. So you need a tissue injury. You need to prove that that tissue injury is due to antibodies, and you need to demonstrate those antibodies. So these three are the criteria to say that this is a chronic active antibody-mediated rejection. Now, let's learn about the spectrum of ABMR. It is easily told here that, okay, show me a tissue injury. Yes, the pathologist will be able to show that. And then show me that this is due to antibodies and show me the antibodies. So that becomes really problematic. What about the spectrum of ABMR? Now, recently, when people started doing routine protocol biopsies, the concept of subclinical ABMR is being much appreciated. Now, this especially comes from a major French study where they have this protocol of routinely biopsying patients, whether they have DSA to start with or do not have DSA to start with. Now, in those biopsies, when they find that the patients are completely normal clinically, creatinine is fine, no proteinuria, but the biopsy is fulfilling criteria for BANF, antibody-mediated rejection, that becomes a subclinical ABMR. In a large study of nearly 900 patients, you can see here that this black line is the survival curve when the patients have no rejection. The blue line is patients when they have subclinical TCMR, and the red line is the subclinical ABMR. All this are protocol biopsies done at 12 months. So this is a huge study which said that subclinical ABMR is bad. So that's one. And then the second spectrum is, like we discussed in the previous BANF definition, C4D positive and C4D negative. Now, all major studies have shown that when we look at a series of patients with transplant glomerulopathy, only a small proportion of them, like about a quarter to third of them, have C4D positivity. What happens to the others? Can we say that it is not due to antibodies just because C4D is not there? No. C4D simply means that the complement component, the breakdown product of C4, which is C4D, is covalently bound to the tissue there, and it is simply not going away by the washing. But more and more, we have started appreciating that C4D negative patients also can have a chronic antibody-mediated rejection. So subclinical ABMR, C4D positive and C4D negative ABMR, and the third thing is antibody-mediated vascular rejection. What it means? Now, in the original BANF classification, vascular rejection was considered a cell-mediated problem. What is vascular rejection? Now, again, in the literature, certain terms will be used in an interchangeable way that led to confusion. Antibody-mediated rejection, humoral rejection, vascular rejection. Depending on the pathologist's way of using these three terms, the report will be a little confusing. What it all means? Now, antibody-mediated rejection is primarily a microvascular problem. For whatever reason, the glomerular and the peritubular capillaries, the vast capillary network in the kidney, is affected. Cell-mediated rejection is mainly a tubulointerstitial problem. The tubular epithelial cells are primarily affected there. Now, the major blood vessels in the kidney, not the microcapillary system, the major blood vessels in the kidney were thought to be primarily involved when you have a vasculitis or an endothelialitis, meaning that CD3 positive T cells is infiltrating the vascular endothelium, similar to a CD3 positive T cells infiltrating the tubular epithelium, what we call it as tubulitis, when a similar finding was appreciated in the major blood vessels, that was called endothelialitis, and that was considered to be a T cell mediated problem. Again, a major French study, a population-based study, found that that may not be the case. So this paper was published in Lancet 2013, where by a statistical technique known as principal component analysis, the vast majority of rejections were able to be divided into 4 subgroups. One, this red line, which is classical acute cellular rejection without a vascular involvement, cellular rejection with vascular involvement, antibody-mediated rejection without vascular involvement, and antibody-mediated rejection with vascular involvement. So when there is endothelialitis or what is known as a major blood vessel involvement in rejection, that could also be part of antibody-mediated rejection. So how do we tease out all this? Now, in simple terms, we can remember like this. Cell-mediated rejection is a tubulointerstitial problem. You have interstitial inflammation. Those infiltrating cells, mainly lymphocytes, are injuring the tubules, and this tubulointerstitial rejection is predominantly a cell-mediated problem. When the microvasculature, the glomerular endothelium, and the peritubular capillary endothelium are affected, that becomes a microvascular rejection, which is predominantly an antibody-mediated rejection. When the major blood vessels are involved by what is known as endothelialitis, that could be related both to cell-mediated rejection and to antibody-mediated rejection. So we learned about subclinical ABMR, C4D positive and C4D negative ABMR, antibody-mediated vascular rejection. And then, of course, TG is the one that we are dealing with now. And in between, something known as a non-HLA antibody-mediated rejection. So again, what is it? When we repeatedly say antibody-mediated rejection, we mean, for all practical purposes, anti-HLA antibodies. But there are, as you well know, there are several other non-HLA antibodies that could also cause antibody-mediated rejection. One recent paper published in JASN this year, again, the French group from Necker Hospital, found what is known as naturally occurring antibodies, or NAPs. This was primarily directed against something known as melanaldehyde that gets altered due to environmental stress and for several reasons. So you get what is known as a naturally occurring antibodies, and this group, again in a large cohort of kidney transplant recipients, wanted to find out whether this naturally occurring antibodies measured by an ELISA technique are in any way detrimental to graft. So they divided the survival curves into 4 groups. The black one is no DSA. By DSA is the classical anti-HLA antibodies. So no anti-HLA antibodies and no naturally occurring antibodies. They do well. The green line is DSA positive. And if you take this red line, which is the worst graft survival, has both naturally occurring antibodies and the classical anti-HLA antibodies. So what does it mean? So this is all preliminary data that's coming in. More and more centers have to validate this. But at this time, we need to know that, or we need to keep in mind that it is simply not the HLA antibodies that are involved, but there could be several known and unknown non-HLA antibodies that could also play a major role in causing graft dysfunction. Now, we learned about DSAs. Now, what about C4D? What is this C4D? And primarily the question that we want to address is, when we say peritubular capillary C4D is sort of a signature that an antigen-antibody reaction has taken place, right? Once upon a time, 10 years ago, C4D was considered an important or the criteria to diagnose antibody-mediated rejection. Now, of course, as I made it in the previous slides, C4D positivity is not an absolute requirement for diagnosing antibody-mediated rejection. So why is C4D should be in peritubular capillary to make a diagnosis and not in the glomerular capillary? Again, remember that normal kidney biopsy has some glomerular capillary C4D that's always there. We still do not know the exact reason why peritubular capillary C4D is abnormal and not glomerular capillary. One postulate by Dr. Colvin, a pathologist, is this. Now, there are 4 major cell surface inhibitors of complement activation that are abundant in the normal glomeruli. They are this complement receptor 1 or CD35, membrane cofactor protein or CD46, decay accelerating factor or CD55, and protectin or CD59. So why it's present more in glomeruli? Because there is always a constitutively active classical pathway complement activation that's taking place in the glomeruli, and we have plenty of defenses to prevent a formation of membrane attack complex and the term and cellular injury. Whereas in the peritubular capillaries, there is only CD59. So peritubular capillary surface, the classical pathway activation is relatively unopposed compared to what is happening in the glomerular capillary. So for whatever reason, when there is a complement, when there is a classical pathway activation, then glomerular capillaries are probably protected well, whereas peritubular capillaries are not. And there is nothing to oppose that because there is only one CD59 that's present in the peritubular capillaries. Again, to quickly go over the complement pathway, you have a membrane attack complex, which is from C5b to C9. This membrane attack complex is forming from C3, which is the pathway where the classical and the alternate is converging. The classical pathway is C4 and 2, and alternate pathway is factor B and factor D, which results in C3 formation. And antibody-mediated rejection is a classical pathway involvement. That's why you have C4D that's getting deposited there. Okay, now little more about DSA. Again, the problem in the definition of TG, in the diagnosis of TG, and the confusion in the literature about TG is simply because it involves 3 major people who are dealing with this: the pathologist, the clinician, and the histocompatibility people who make this diagnosis of the presence of DSA. Because these 3 people do not communicate among each other with the common terms, there is some confusion in the literature. What is positivity? What is negativity? When do you call something as positive? What is an MFI value? What is the strength of the DSA? Those things. So when DSA is reported as absent, what does it mean? So we simply say that, okay, I'm suspecting antibody-mediated rejection. Let me send DSA to the lab. DSA is reported as negative. We don't communicate with the lab. Just like any other lab findings, we simply go by that okay, DSA is absent. What does this absence mean? Now, DSA is typically reported as a MFI value or a mean fluorescent intensity. Though the FDA has not approved MFI as a continuous scale to be used for diagnosis, in reality, MFI is reported in numbers. It's a continuous number. Though, there we put a cut point and say and dichotomize the MFI value and call something less than that cut point as negative and something more than that cut point as positive. That varies among laboratories. So where to put that cut point and say that below this I'm going to call negative and above I'm going to call positive, that is a confusion. So when somebody is reporting as DSA negative, we need to make sure that what do they mean by negative? Say, for example, our lab has an MFI value of 2000 that is reported as less than 2000 is considered as negative. Now, couple of times we encounter patients where they develop antibody-mediated rejection or a transplant glomerulopathy. You look at the DSA at that time of biopsy. Let's say, I'm just throwing some examples. Let's say the MFI value will be 3500. This is negative. This is positive. Look back at the time of transplant, they will have a value of 1500. So by definition, this 1500 MFI is negative. So is this considered something as this patient was immunologically clean and post-transplant they developed a de novo antibody and developed an antibody-mediated rejection? Or does it simply mean that they had a very low titer antibody? After transplant, the antibody titers increased and they are having antibody-mediated rejection. Now, this sort of confusion happens every day in the clinic, and especially when this is being reported, when we read a literature about DSA, we need to be careful when somebody says MFI value is negative or positive. Again, the next confusion happens when it's reported as it's measured at one time at the time of doing biopsy and it is reported as absent. What does it mean? What about earlier time points? Did the patient was the patient pre-sensitized prior to transplant? So that is one thing that needs to be looked at when DSA is reported as absent at the time we are making a diagnosis. And then traditionally labs are reporting HLA as only in 3 alleles, HLA-A, B, and DR. What about others? Now again, in current opinion, recently there was a paper by a well-known certain immunologist who deals with DSA on a daily basis. Her argument was that HLA-DR is the most studied HLA class 2 molecule because it is more amenable for testing in vitro and in vivo than HLA-DQ and DP. Thus, our understanding of HLA class 2 involvement in immune process is mainly based on the role of HLA-DR. So she finishes the paper by the argument that I postulate that these nuances may be the cause, at least in part, for the increased immunogenicity of HLA-DQ in the context of solid organ transplant. So what it should be kept in mind is that with majority of the lab, when they report only A, B, and DR, it is possible that DQ and DP, which we are not testing routinely, could also be relevant to DSA. And then finally, after this, other antibodies, when DSA is reported as absent, recent papers are bringing in more about this, that DSA strength by titration rather than MFI is important. So an MFI value or a mean fluorescent intensity value can reflect one thing. When you dilute it, just like any other antibodies, the strength is better reflected by titration values rather than by MFI values. And finally, there is something called a complement mediated prozone effect. What it means, you can have tons of DSA, but they are not reacting in vitro because of this in vitro complement formation and preventing the secondary antibodies to bind and light up. So this is called a prozone effect, and to prevent this prozone effect, people started routinely using EDTA treatment to the sample. So the moment a DSA is reported as absent, the question is, one needs to ask is there a complement mediated prozone effect? Was this EDTA treatment? Was this the sample treated with EDTA? Now, all these are relevant when we try to find out why is the patient having a morphological evidence of antibody mediated endothelial injury, but I'm not able to see any antibodies. Now, there was a recent paper in AJT 2018, which was titled Sensitization in Transplantation, Assessment of Risk, or STAR. This is a 2017 working group meeting report that brought out salient points. One, the strength of the DSA as determined by MFI is not equivalent to the titer of the DSA. 0% PRA doesn't mean that the patient is immunologically naive. Acceptable HLA mismatch doesn't mean that patient is immunologically naive. Pre-transplant DSA titer does not reflect or is not equivalent to post-transplant memory response. Complement binding activity in vitro is not equivalent to in vivo complement binding activity. Lack of donor HLA loci typing is not equal to the absence of DSA directed to that HLA loci. Again, it's reflected here. So simply because you typed only ABDR and then said that DSA is negative doesn't mean that there cannot be antibodies directed against other loci. Failure to routinely use methods to rule out serum inhibitors in HLA antibodies, like this EDTA treatment, leads to under recognition of DSA. Failure to consider shared epitopes between solid phase beads leads to under recognition of DSA. What is all this means? It means that the DSA science is not perfect. So whenever we try to make a diagnosis of transplant glomerulopathy, or whenever we see double contours, before we jump to the conclusion that, oh, there is no antibody here, we need to make sure that we haven't missed any of this. And then again, there is this problem of mixed acute rejection. though Banff has made it black and white that rejection can be cell mediated and rejection can be antibody mediated, a significant proportion of antibody mediated rejection patients have mixed cellular and antibody mediated rejection. So this is again our own study where in a from about 87 kidney transplant recipients who were by definition C4D positive AMR, we found that about 32 of them also fulfilled the definition of T-cell mediated rejection by Banff. When we divided them into a T-cell, a presence of a concurrent T-cell mediated rejection and presence of a pure C4D positive ABMR without concurrent T-cell mediated rejection, there was a survival difference. Patient with concurrent T-cell mediated rejection or a mixed rejection had approximately like 2.5-fold higher risk for graft failure after adjusting for several other variables. Now we learned about TG pathogenesis. I mean, we learned about DSA, we learned about C4D. Now, what about the pathogenesis of DSAs in ABMR? Now, when we say endothelial cells are injured or endothelial cells are destroyed, what does it mean? Now, there are three proposed pathogenesis of donor-specific antibodies in antibody-mediated rejection. Now, donor antigen-presenting cells will include dendritic cells, macrophages, B cells. Now, complement-binding donor-specific antibodies target HLA class 1 that's present on the endothelial cells, activate the classical complement-mediated pathway, and then cause cell lysis. Now, this is what is known as CDCC or complement-dependent cell-mediated cytotoxicity. Very simple. We have an antibody, we have an antigen expressed on the endothelial cells, which is a HLA antigen. There is an antigen-antibody interaction. Complement is fixed, complement pathway is activated, and the membrane attack complex injures the endothelial cells. The endothelial cell dies. Now, what about complement non-binding donor-specific antibodies? So these antibodies recruit innate immune cells like NK cells and macrophages and neutrophils through the Fc receptor and lead to what is known as an antibody-dependent cellular toxicity or ADCC. Here, so the Fc receptors, the NK cells, macrophages, neutrophils, the Fc receptor causes the interaction of these cells with the endothelial cells, leads to degranulation of these cells, lytic enzymes, tissue injury, and cell death. So this pathway is what is known as ADCC or antibody-dependent cell-mediated cytotoxicity. So both these pathways, whether it is a classical complement activating pathway or Fc receptor-based antibody-dependent or a complement non-binding pathway, both of this results in cell death. Does antibodies always cause cell death? No. So again, this pathway can cause direct stimulation and pleiotropic effects, which results in growth factors, leukocyte recruitment, tissue injury, and endothelial proliferation. So this is what is resulting in the endothelial remodeling. So when I say transplant glomerulopathy is double contouring, new basal membranes are being laid. Now this is all happening because the endothelial cells are not dying all the time. So simply when we say the endothelial cell is injured, the injury can be two types. One, a lytic injury where the cells are completely dead. Another one is a partial injury where the endothelial cells are in fact activated, which results in eventually in endothelial proliferation. So again, mechanism of antibody-mediated endothelial injury. HLA antibodies cause graft injury by inducing phenotypic changes in the donor vasculature. Now, complement activating antibodies trigger the classical pathway by binding to C1q, resulting in production of C3a and C5a. And then monocytes, neutrophils, and NK cells that express Fc receptors, they can interact with the heavy chain of the HLA antibodies, which is bound to the donor endothelial cells. And this is what I meant in the earlier slide as antibody-dependent cell-mediated cellular cytotoxicity. Now, for complement to get activated, C1q is the most important factor. Now, C1q is the most important factor that triggers this complement activation. Now, okay, so antibody subclass determines the propensity for C1q binding. So not every antibody binds to C1q. So if C1q is the trigger, then not every antibody binds to C1q in an equal fashion. Say, for example, IgG3 is recognized by C1q, whereas IgG4 is a poor C1q binding partner. In fact, this is a French study. One study showed that the antibody that was present predominantly in acute AMR was IgG3 subclass, whereas the one that was predominant in a subacute or a subclinical AMR was IgG4 predominant. Again, these type of studies has to be validated in other centers, but it is important to remember that not all antibodies trigger this event. What is this event? Making a C1q bind. Now that event is not equal for all antibodies. IgG3 and G4 may differ. Again, this is reinforcing the fact that this is not all antibody mediated, not all an complement fixing problem, but you can also have an FC mediated function that can contribute to graft injury, where monocytes, tissue macrophages, and NK cells play an important role. And then this DSA-induced inflammatory loops, what does it mean? At every stage, both in the ADCC and the CDCC, you can have amplification of this loop that results in an ongoing tissue injury. Now, recent studies have identified a novel role for endothelial cells and complements in antigen presentation and stimulation of allogenic T cells. So there are pathways that the way the endothelial cells can activate CD4 and sort of amplify this loop. Why is this all important? This is important because endothelial injury, again, is not simply a cell death, but in TG predominantly, it is all cellular remodeling, and that happens because of this amplifying inflammatory loop here. So finally, if the histological manifestation of AMR are macrophage infiltration, complement deposition, endothelial swelling, and endothelial changes in endothelial swelling, the determinants are the subclass of the antibodies, the glycosylation status of the antibody, the antigen density epitopes, and the concentration of the antibody. Now, we repeatedly say antibody-mediated rejection. What about cells in antibody-mediated rejection? Now, this again is our own study where we did immunophenotyping. This was for a different purpose, but it is important to appreciate that when we immunophenotyped well-defined phenotypes, well-defined biopsy findings. Say, for example, this 11 patients were acute T-cell mediated rejection. There were 7 active antibody-mediated rejection and 11 chronic active antibody-mediated rejection. Now, these 3 biopsy categories was looked repeatedly by 2 pathologists independent of each other to make sure that this is what is the phenotype. So in other words, these were pristine, the best selected acute TCMR, active antibody-mediated rejection, and chronic active antibody-mediated rejection. When we did T cells by looking at CD3 positive cells, CD68 positive cells, and CD20 positive B cells, we can see here, both in chronic active antibody-mediated rejection and active antibody-mediated rejection, you will find CD3 T cells more than macrophages or B cells. So what does it mean? So though we sort of compartmentalize as something as cell-mediated rejection and antibody-mediated rejection, it is important to remember that CD3 positive T cells, mainly the CD4 T helper cells, play a major role in antibody-mediated rejection, whether it's an acute or a chronic antibody-mediated rejection. Both in terms of, as we saw here, in terms of causing endothelial injury and amplifying the inflammatory loop by this ADCC mechanism, cells play a major role. So though the Banff repeatedly says it is an antibody-mediated rejection and a cell-mediated rejection, in reality, the immune system is not that compartmentalized. For an antibody to produce an act, you need the help of you need the active help of T cells. Now we say DSA and non-HLA antibodies. So what are these major alloantibodies and autoantibodies? This is a partial list of what are these antibodies that we're talking about. ABO, of course, is the most important antibody. And then when we say antibody-mediated rejection or DSA, we are primarily referring to HLA. And there are several non-HLA antibodies also. Now, in order to give a sense of how does this patients with TG, how are they, what is their demography, and how do they behave, I am going to next present for the next few minutes our own study. This was done by Dr. Pallavi Patri, who is now a nephrologist in Bangalore. Now, we looked at 92 kidney transplant recipients who are all by definition transplant glomerulopathy, which is double contouring. And as you can appreciate here, about 25% of them had prior episodes of acute rejection. So it's only 25. So the vast majority of them did not have a biopsy proven acute rejection. What it means, this again means that there is an acute insult which results in a remodeling. That's only happens in a minority of patients. The vast majority have some form of a chronic ongoing endothelial injury that results in endothelial remodeling, which causes transplant glomerulopathy. So here is the findings from this, the Banff findings from these 92 biopsies. Now the red is Banff 3, Banff 2, Banff 1, and Banff 0. G is the glomerular score, PTC inflammation, vascular inflammation, CG. So we can see here that a significant proportion of patients with transplant glomerulopathy had acute inflammation also, as evidenced by glomerular and PTC scores. Again, these are all univariate analysis where we looked at several risk factors and the hazard ratios. And what we did was we did a principal component analysis where we tried to club or try to reduce all the pathological variables into smaller number of variables. So we took 14 histopathological variables. The goal here was to identify variables that are closely associated with one another so that it can be combined. So as you can see here, the interstitial fibrosis, tubular atrophy, and total inflammation, as expected, were all clubbed together. Interstitial inflammation and tubulitis were clubbed together. Microvascular inflammation, peritubular capillary, and glomerulitis were clubbed together. So once we had this PCA information, what we did was we simply combined their band scores and created a single numerical value. So we created a new score. So we call that an acute tubular interstitial score, where we combined I plus I and T scores. We called another score as a chronic inflammation score, where we combined CI, CT, and TI. And then we combined a chronic arteriolar score, where we added AH and CG scores together. You can see here that this is AH and this blue is CG. They are close together. These three were all made into one, and this was made into one, and this was made into one. So when we combined like that and looked at the independent risk factors by a Cox regression, there were three variables, not surprising at all: serum creatinine at the time of biopsy, proteinuria at the time of biopsy, and a chronic inflammation score. So there is nothing surprising here. So higher the creatinine was the outcome, higher the proteinuria was the outcome, higher the chronic inflammation and fibrosis was the outcome. So these were the three independent risk factors for graft failure. Then what we did was, in a statistical model, we combined these three variables. We took these three scores and then created a prognostic index. And that prognostic index, based on the prognostic index, we divided the patients into three groups: somebody with a low prognostic index score, somebody with an intermediate prognostic index score, and somebody with a high prognostic index score. And then we did survival curves Basically, we are classifying based on the prognostic score into low risk group, medium risk group, and a high risk group. And here again, we have their survival, the graft survival percentages here. What it means now, for the first time, though these variables are traditional variables for any chronic kidney disease, for the first time, we have a prognostic score that allows us to tell to a reasonable extent the graft survival percentage of a patient who is sitting in front of us. Now, when somebody comes with proteinuria and graft dysfunction to a biopsy, and that biopsy is showing transplant glomerulopathy, based on the pathology findings, the inflammation, the proteinuria, and the creatinine, you come up with a score and categorize the patients into groups. Then what we did was, in order to validate this, we obtained data from a French cohort. This was a 47 kidney allograft recipients with transplant glomerulopathy. We applied our same score to these patients and more or less came up with similar survival curves. This statistical model was validated in this independent cohort of 47 transplant glomerulopathy patients. Similar to this, there was a new study published this year, again by the French group, where they came up with a dynamic prognostic score for ABMR. So what they did was, in 278 ABMRs, based on DSA, graft biopsy, GFR, and proteinuria, they came up with a score, and then standard of care treatment, and based on how they responded to standard of care treatment, they came up with another score. So this again, they were able to divide them into low risk, intermediate risk, and high risk, and this was also validated. So this again points out that when somebody has transplant glomerulopathy, by certain traditional risk factors and the way in which they behave, we can, to a reasonable extent, we can sort of come up with a prognosis of their graft. Now, what about biomarkers? Now, our lab has been involved in urinary cell mRNA profiling as non-invasive tool to assess kidney allograft status. Over the years, we have looked into several messenger RNA signatures in the urinary cells to non-invasively diagnose acute rejection, to prognosticate acute rejection, and to sort of anticipate acute rejection. Now, based on this approach, we published a study that looked at a two-step model to differentiate acute cell-mediated rejection from antibody-mediated rejection. So what we did was, we studied 26 patients with acute T-cell mediated rejection, 26 with antibody-mediated rejection, and 32 with tubular injury. Step 1 was to distinguish both these rejections from tubular injury. So when somebody presents with an elevated serum creatinine, by looking at their messenger RNA profiles in the urine, we'll be able to say whether this is a rejection versus ATI. And then, using the same gene expression, came up with another signature that will distinguish ACR from AMR. So this is again the predicted probability of acute rejection compared to ATI with an AUC of 0.92. Step 1, based on 6 genes here, it's listed here. And then in step 2, based on 5 genes, we can distinguish acute cellular rejection from antibody-mediated rejection. So this is one biomarker that's available that uses urinary cell messenger RNA profiles to distinguish AMR from ACR. We are also, because it is blood vessel involvement, we also thought more than urine, probably circulating markers will be a better biomarker. So we are now in the process of looking at circulating extracellular microRNAs. We had earlier reported in a conference abstract that in a small proportion of patients that circulating extracellular microRNAs may be a better discriminant of AMR compared to, not maybe a better discriminant, but circulating microRNAs can be used as a biomarker to distinguish antibody-mediated rejection. Now, the other biomarker that's being used and that's getting popular is what is known as this alloSure, which is plasma donor-derived cell-free DNA. This utilizes a targeted sequencing of 266 single nucleotide polymorphisms to quantify donor-derived cell-free DNA in circulation. So from the plasma sample, you isolate DNA, and in that DNA, you are able to determine what is the percentage of that this DNA is coming from the donor versus it is coming from the recipient. And based on a cut point of 1%, and this 1% cutoff has a positive predictive value for ABMR diagnosis of 44% and a negative predictive value of ABMR diagnosis in 96%. This was published in JSON last year, which simply says if in the pool of circulating cell-free DNA that I have, if the donor-derived component is more than 1%, then my predictive value for ABMR is 44%. So this is what is the donor-derived cell-free DNA. And again, the other, besides the messenger RNA and the cell-free DNA, another approach is using the urinary CXCL10 protein. Again, this is a French study that looked at 244 kidney transplant recipients, where there were 37 pure ABMR and 31 mixed ABMR. Elevated urinary levels of CXCL10, which is also known as IP10, which is a chemokine, had a very high negative predictive value for the diagnosis of ABMR. Interestingly, when they combined urinary levels of this with the DSA, this improved the diagnosis of ABMR. Banff, in their most recent update, came up with this list of pathogenesis-based gene transcripts. So as you will recall, one of the ways in which antibody-mediated rejection is diagnosed as a part of a criteria for diagnosing antibody-mediated rejection is simply the presence of gene transcripts. Again, gene transcripts has not become routine because it will depend on lab and who is doing what, but these are a big list of genes that can be used to provide information whether there is an endothelial cell activity, and in that way it can be used to diagnose antibody-mediated rejection. Now, so far we have been talking about endothelial cells and transplant glomerulopathy. But what about the other side of glomerular basin membrane? Now, one study that was published a couple of years before from University of Michigan, they looked at the other side of the glomerular basin membrane, the podocyte. Their argument was that transplant glomerulopathy is primarily a podocyte problem. So there is a podocyte loss from glomerular basin membrane, and mechanistically, there is a difference in podocyte loss between late TG and early TG. Now, in late transplant glomerulopathy, the primary mechanism underlying podocyte injury and detachment is similar to that observed in the 5-6 nephrectomy model. That is, glomerular enlargement exceeds the capability of podocytes to hypertrophy, leading to podocyte stress, injury, and detachment. Whereas early was mainly an immune-mediated injury. So this obviously has to be validated in other studies. Now, what to do with transplant glomerulopathy? Again, so far you would have appreciated by now that transplant glomerulopathy is simply a morphological term, which means that there is a remodeling. So more important is prevention rather than trying to do something when there is already remodeling. So as of now, once we have found that there is remodeling and double contouring in the biopsy, nothing much can be done other than slowing down the progression. So there can be desensitization protocols, treatment of active ABMR, and treatment of chronic active ABMR. I'm not going into any individual studies because of the fact that none of the studies so far have, in a conclusive terms, established that one particular regimen is superior to another. So I'm simply listing all that's present here. And what are those treatment options available? Anti-CD20 monoclonal antibody, proteasome inhibitors, IL-6 receptor blockade, C5 inhibition, C1q inhibitors, this IDIS, which is the immunoglobulin degrading enzyme of Streptococcus pyogenes, which will sort of break down the antibodies, our traditional IVIG or intravenous immunoglobulin, plasmapheresis, thymoglobulin, and steroids. Now, each center has their own favorite way of treating transplant glomerulopathy. But as I told you, prevention is probably a better way. How do we prevent? Early identification of endothelial injury, early identification of the presence of DSA, and sort of steps to prevent the DSA endothelial cell interaction. So does treatment help? Our own study though this was a retrospective analysis, did not find any difference of treatment. So we have, of the 92 patients, we had 46 who received some form of anti-rejection therapy, and the other 46 did not receive any anti-rejection therapy. There was no difference in survival. Now, because this was a retrospective study, and the reason why somebody would have received an anti-rejection therapy itself would have been biasing these results, we did a propensity score analysis to sort of mimic a quasi-randomized trial. Now, based on the propensity score analysis also, we did not find that the treatment was in any way significant. But maybe it'll be of some help. Now, this is a study published from University of Wisconsin where they looked at 123 patients with chronic chronic antibody-mediated rejection as per the Banff criteria. Again, retrospective study, but they found that treatment compared to no treatment may be of some benefit. I will stop here and take any questions. Thank you.